Yeah, thank you, Atul. I included this because during the last presentation, this virus part was not there. So I thought this will sort of conclude the PD insertion. And I think here on we'll go on to the discussion of AVF and this. And we have the panelists, and there are people other than panelists also, Dr. Vijay from US, Dr. Adrian, and Dr. Shuganya, a pediatric nephrologist who does AV fistulas in great numbers and successfully too. And I think we'll start rolling the discussions and any more additions from the panelists and the audience. I think from
my side, I just wanted to say this is fantastic work. It gives us a lot of encouragement that we are, or you guys who are doing so much of it are just as good as anybody else. You know, when we do it, studies have shown that if nephrologists do it, the prevalence of AV fistulas in their population increases. Plus, we don't have to depend on anesthesia, at least in this country here in the United States. You know, if a potassium goes up 5.5, they're looking for every reason to cancel a case. And while we are not afraid of potassiums of 5.5, others are. And so at least when we do it, we overcome this, additional burden of having the anesthetist on board. That's what I wanted to say.
Yes. Dr. Vijay, you want to add something from?
Yeah, I think I'm very impressed with the work you all are doing. I think it's very nice. And I agree with Adrian, that's been the issue. I've seen it from both sides. We used to have an outpatient center, office-based, in which we did interventions. There were some reimbursement issues happen in the last couple of years, so many of the people have not been able to keep it or keep ambulatory surgery centers. So when we were there, we used to do everything under local, a little bit of sedation. We made fistulas. We really did not do any grafts because that was not cost effective or time effective there in an outpatient center. But in the last couple of years since that center moved, we went to the hospital. And doing interventions has not been a problem. But again, I think as many of the speakers spoke, there are a lot of other political issues that happen in the hospital. So some of the main hospitals, you know, it raises eyebrows, then you have to talk to a lot of people, you know, and you just have to be cooperative. You have to be looking at the patient's best interest. So we know your limitations and whom to call and when to collaborate. But you guys have illustrated that very nicely.
I also wanted to add one more thing. You know, it's also about money. In the United States, it's all about where the money is. And I was just looking at some data that I have from 2010. To create a simple fistula for the surgeon was $610. And that is the radiocephalic. When it comes to brachiobasilic or brachiocephalic, it goes up to $800. So that's a significant amount of money. And so if you can understand why the surgeons are apprehensive, that was 2010. It must be more now. But you know, things have changed, and now we have endovascular AVFs. So I'm hoping that if nephrologists cannot create surgical fistulas, then we at least have that option of creating endovascular AVF.
But that would be even more costly, no? For the patient, endovascular AVFs?
Yeah,
no,
actually.
I'm sorry. It depends, because the endovascular AVF, we don't have to go to the OR. We're in the suite. At least I'm in a training institution. It's not that much. But if you put it in an OR, then they have to pay overhead of the hospital, the nurses, OT time, all of that is extra cost, plus anesthetists. We don't have all that if we do it in our suite. Vijay, sorry, you were saying something?
I think one of the things which I didn't have time to emphasize was the role of duplex scanning and ultrasound mapping of the arteries and veins, particularly if you are thinking about getting into endo-AVF creation. There is so much to be learned about the anatomy of the arteries and veins and the location where they are close by to each other, and not only the creation, after creation, looking at the branches and then trying to embolize them or ligate them. So I'm sure it's possible for anybody who is willing to put in the effort and time, but even in the many other failures of the fistula in our experience could be anticipated and quite often prevented if we had duplex surveillance or duplex assessment of fistulas periodically. And that's one skill which is very useful for any clinician to learn. And the advantage of duplex scanning is that you don't have to have a doctor to do that. If you have a trained nurse or somebody with common sense and science understanding can be trained to scan your fistulas. In our hospital, we don't scan our patients. It's all done by the vascular scientists, and they are mostly science graduates with experience in scanning ultrasound. They get trained in doing ultrasound. And if you don't have a formal training program, you can train them informally and they will get better with time. And if they are doing only duplex scanning all the time, they get extremely good at it, sometimes much better than our radiology colleagues. So that's something which I do not know how easy or difficult it's because you need to have a certain volume of work to employ a person to do the scans. But if you work in a setup where they can be used for other scans, then that will be financially viable. And also, even standard ultrasound scanning in many European countries are not done by doctors, so you can get nursing colleagues or technology colleagues. But the question again will be money, because if you do it yourself, you can charge. If it's done by somebody else, then you have to employ them or they may charge. But in terms of clinical outcome, having the access to proper duplex scanning of AV fistulas, both in surgical and potentially in the future when you're going to create endofistulas, that's a great tool to have and get used to.
Thank you, Joseph. Welcome, Kumbar. And listening to Adrian and Vijay, now I know why endovascular AV fistula is being encouraged more in your place. That is because nephrologists want to bypass the resistance from surgeons for open AV fistulas. Is that so?
It's an interesting, can I comment on that?
Yeah.
So I think that is a big issue because it's very difficult. There was a couple of reimbursement changes that happened a few years ago that make it harder for office-based procedures in nephrology. And so people have to invest money and make a standard ambulatory surgery center, which has many more requirements, even if they're not using anesthesia, even if they're doing local anesthesia and sedation. So that created the thing. But when we were doing the fistulas in our office-based setting, in a procedure suite that's next to this, our cost, material cost, forget labor cost or whatever, is $70. That is the biggest expense was if we were using Proline or the CV8 suture that costs about $10 in the US. I'm sure it's different costs in different countries. The rest of it is for prepackaged things such as the OR draping screen. There's the cautery machine, the part that is, that's disposable, etc. But it's a very low cost. The people that are doing the AV fistulas in the same centers now that are doing percutaneous, the equipment cost is $5,000 to $6,000. So they may not even have, it takes a little longer to make the open fistula. Maybe we'll do, I don't think we get times as Dr. Venkraman, who does everything in 34 minutes. We're probably still at an hour, but they're doing some fistulas very fast that are percutaneous, but it still doesn't justify the total cost to the health system yet. That's what we're seeing. But to the nephrologist, it will justify the cost because he will get the fee. That's the dilemma in the United States right now. But I think that if we can sort through that and more people are trained in open as well as percutaneous, then you get into a situation where you can offer the best option to the patient. The problem in medicine, I think Dr. Joseph has alluded to that, is that and if you look back in the history of coronary bypasses, there were all these trials like the Berry trial and all these other things, and people stood their ground that bypass is always better than stent. But if you ask them if they want their chest cracked open, they'll ask for a stent the first time, depending on the circumstance, right? So we never want to be in a situation as nephrologists that because I can do this, because I can do a percutaneous PD catheter, I will do this for this patient. I will try to do this for this patient, when maybe the laparoscopic surgeon can offer a better result. Maybe somebody else who can do a necklace graft or some other special thigh graft can offer a better result. We should be ready to give that up. But the more broad our knowledge is, the more we can offer to the patient. I think that's a very common thing.
Thank you. Then coming to the procedure per se, Shailendra, that brachial anastomosis, won't you tie the distal end of the vein? Side to side you demonstrated.
Yeah, that's a very good thing you pointed out, sir. Whenever we make a side-to-side anastomosis, we always have to tie the distal end of the vein. Otherwise, the patients will have the venous hypertension and edema of the involved limb. So I always tie the distal part of the vein after doing the side-to-side anastomosis. That's a very important thing you pointed out. Yes.
Dr. Adil, about the length of the arteriotomy, you have any suggestions? Brachial versus radiocephalic. Should we be careful? Is Adil around?
Yes. Are you?
Yeah.
Am I audible?
Yes.
Yeah. So for the
Be
radial,
careful about the length of the
for
arteriotomy.
arteriotomy for radial is I take more arteriotomy, even especially when the artery is around 1.6, 1.7, or 1.8 around. I take a longer arteriotomy of 6 mm. But for the brachial, I take around 4 to 5, not more than 5, because if the cephalic vein is good and there is some calcification, you should go for the small arteriotomy for particularly the brachial artery.
Yeah.
Bala.
Yes, Rana Saab. Yeah.
I just want it is fine for beginner to make a side-to-side fistula, but just maybe there. Actually, it is not advisable to make side-to-side fistula. We should make and when side artery. And that it takes little time to run that, but that is the practical. And we should try to make all fistulas on radial artery as possible. Brachial artery fistula should be very rare whenever is not possible. So though it's very easy because brachial artery is very big, but brachial artery fistulas are not desirable if the good radial artery is available. So that is what I would like to say. And I like that young people are learning that, and there are a lot of methods we could have discussed. But really, it was very nice to listen to Joseph. And these young nephrologists should learn from Joseph that those are the various tricks which we should practice. Thank you.
Thank you, Dr. Rana. Yes. So what is this? Lot of noise coming.
चार बोलना दो ही
Tangapandi,
Yes, sir.
yeah, to mute mics of people who are not
Done, sir. Done.
Yeah. Yes, Venkatram, carry on.
Actually, we are creating fistula for the patient's sake because that's what is the stand from nephrologist because Rana sir is there, Narayan Prasad is there, they are secretaries, and even Gangaram also they are creating fistula, even SGPG Lucknow also they are creating fistula. So what is the supporting thing from Indian Society of Nephrology, sir? Because nothing happened, I am just asking for the nephrologist because Joseph sir told that it's other boundary, but even though other boundary,
I don't know what nothing has happened so far. During last 40 years, nothing has happened. I don't know what future, but it's a legal point of view. But so far, there was no instance that we faced any medical legal problem ever. More than 45 years, I have been making this in my center has been doing it.
Can I say something?
Yes.
I'm just impressed. Like if you look at the literature, usually when you have fistula creation, anywhere from 50 to 70% will fail as primary failure. But you guys are not seeing it. At least when you guys are making from all the literature you showed me just now. So how are you avoiding that failure rate? How are you minimizing juxtaanastomotic stenosis? What are you all doing?
So the main thing may be the selection of the patient, because if you are creating preemptive fistulas, the vein will be good and the artery will be good, and it is very easy. For example, when the patient admitted for during dialysis, he might have go for venipuncture like in diabetic patients or any other admission, ICU admission, they may lost all the veins. But if they are before going for dialysis, I think the vein is good, and that's why the reason. And also you will have more time also, because even in 2 months also they may have time before going for dialysis. That may be the reason. What I am thinking is personally.
But don't you think if they're sick in India, they'll be in the hospital more often, more IVs and stuff like that? In spite of that, your outcomes are so good.
Like Adrian, the problem is most of the data projected by Indian observers they don't last long. Just because here maintenance dialysis is until transplant, and pure dialysis is not that long enough, like in your place there. So maybe we don't get to see this as much as you see.
Dr. Bala,
Yes,
can I comment on this?
yes, Narayan.
Actually, when you look at the ESRD age of the patient in Indian scenario as compared to your Western scenario, as Dr. Adil was talking about, average age of the patient who are going for transplantation are 39, 38 years, approximately 40 years. So that is one reason, average age, and then majority are going for the transplantation. So these are few factors which are the reason for the greater success of the AV fistula. So we have already published our 500 patients experience in Journal of Vascular Access 2 years before. So, and it was looking like outcome was far better than the Western literature reports. The reason being what we have felt, the average age of the ESRD patient in India being approximately 40-45 years, those particularly going for the transplantation as compared to your Western population. So that was the one major reason of this higher success in India.
This juxta-anastomotic stenosis, I would think that in side-to-side anastomosis, the incidence may be lower. What is your opinion? Other surgeons here, Adil, Vijay, Nana.
Hello.
Yeah, this juxta-anastomotic stenosis. Don't side-to-side anastomosis will have less of that?
No. It is not less. Actually, when you follow your patients for the longer period of the times when the patient is there, it is almost equivalent. It is not like that. Because now we regularly follow the patients. Patients are a longer period of the time on dialysis. We see this incidence is not less. Since now we have intervention nephrology at our own center, so majority are going in timely intervention, and then we have resumed this again, the successful AV fistula and early intervention, early picking up, AVF surveillance during the dialysis. These kind of things are coming up, and that are all helping out because there is awareness in dialysis program, dialysis unit also. Sisters used to say, no, there is some flow problems. So picking out, and now in center many times, at least at SGP, we have intervention nephrology, very easy to intervention radiology, so very easy to approach them, and they are also interested in getting the intervention done. So that kind of, it is not that it is less. Just anastomotic stenosis, why there will be less?
No, mainly it is the jet effect, when you have end to side, you tend to, twist the vein and bring it to the artery. I use just common sense approach. I'm just thinking because I do more of side to side, and whenever I do end to side, I make it piggyback so that there is no. Yeah. And these are small things, but of course,
piggyback is really
India, sometimes look so good, to believe. That is mainly because I think because of the duration of follow-up is not as much as in our population.
May I say something?
Yes, Adil.
Yeah. I have made the policy post creation of fistula that I will see the patient on the second day of the fistula. After 48 hours, I will do the Doppler for the flow and the other things for the hematoma and all the things. I will see Doppler and the cephalic arch, cephalic arch I see, and write them all the findings on his paper. Then I will suggest him to come on 14th day, on the 30th day. So if I see the maturation, the valve maturation on the 30th day, on 32nd day, I puncture with the in the procedure room, in my ultrasound procedure room, and send him to the dialysis. This is my practice. And every third month, I go for the surveillance of the ultrasound Doppler for that access what I have created. So that way you pick early stenosis or the problems, definitely. So, and you're seeing the patients in the dialysis or they are coming from the remote areas, but every third month, at least you are seeing as a vascular physician, this dialysis access physician. So you are looking for his access, surveillance is going on. So the chances of picking the late stenotic lesions is less. So you
Yes.
pick it at early stage, one thing. And second thing that I have seen less common juxtaanostomotic segment in side to side. Definitely, there is less chances of side to side in side to side. I have never made the side to side. I go for the end to side only. But somehow I am seeing or I'm doing the Dopplers. But what happens to side? That the cephalic vein, if it is a brachiocephalic or the cephalic vein of the forearm, it gets either thrombosis or it gets the stenosis. That I have seen, and the venous hypertension is much higher incidence of venous hypertension in side to side, and especially in the brachiocephalic.
Yeah.
And
Yeah.
the cause, what I have found, it was very interesting. Cause that that was so there's a stenosis in the cephalic vein near the distal forearm, and the draining vessels were the deep veins of the forearm, that the concomitant veins of the radial artery. So that is the reason they are getting the forearm edema and the head edema. Even I have seen patient with the ulceration, venous ulceration. It's actually side to side. You might have a lot of experience of side to side. So
I
this is the only
always make it a point to tie the distal end. And also, there is an advantage in doing side to side because whenever the vessels are slightly far away and they are pulling when the vein is pulling the artery, I cut the distal end. I don't stop with tying it. I sever the distal end. And if there is some difficulty in flow or some, if you are doubtful, I open the distal end, put in a cannula and test and all that stuff, then retie it. So you have an opportunity without opening your suture line.
okay.
And from Adil, I learned a new terminology. I mean, it is new for me, vascular physician. So Joseph, you may be vascular surgeon, we are vascular physicians.
That's a separate specialty, vascular physician already.
Okay,
Yeah, it's already existing. About the venous stenosis, there are a few things which are applicable from experience in vascular surgery. When you do all these operations, I presume you apply some slings or bulldog clamps close to the anastomosis to stop the back bleeding. One of the reasons for stenosis close to the anastomosis in any vascular anastomosis is the clamp injury, because veins are living tissue, they are not grafts. So when we apply a bulldog clamp, it does cause intimal damage, and we may not know it or see it, but when it starts to function and there's the healing process, you get intimal hyperplasia and stenosis at that area. So in vascular surgery, when we do FEMPA bypasses from femoral artery to popliteal artery using the saphenous vein, which till recently was the commonest vascular operation, you get narrowing of the vein graft close to the anastomosis very commonly, either at the top or at the bottom. And just like Adri was mentioning, it's common practice in many vascular units after a FEMPA bypass to do an ultrasound scan in the first month, 3 months, 6 months, 9 months, and 12 months, up to a year, because all veins have got a tendency to develop intimal hyperplasia, and that is there are various theories and there's loads of literature on that. It's more common close to anastomosis, and more common if you have any injury in the veins. And what I am going to say about the forearm veins may or may not be directly applicable to the Indian versus Western population, but most of the patients whom we see when they come for fistula, they've already had vein puncture in the forearm veins at various levels. And we try to start doing the fistula at the snuff box whenever we can. So when we do that at the snuff box, you have the whole length of forearm vein available to you, but on the downside, even though the vein in the snuff box might be healthy, the vein between the snuff box and the elbow might have been punctured in the past. And also, I had some slides about the duplex. And sometimes when you do a duplex preoperative, you can find segments of vein which are patent but which are thickened inside with phlebitic segment from previous punctures. And sometimes you can find the valves in the veins which are scarred. And normally, if you look at a vein valve during surgery, it's a very, very flimsy, transparent film. Hardly you can see it. But when the valves are inflamed or thickened caused by previous phlebitis, they can be rigid and almost like a septum, causing narrowing inside the vein. So in the ideal scenario, at the end of the AI fistula, if you check the Doppler flow intraoperatively, you can either use a normal ultrasound probe with a sterile, even a cling film or a sterile glove on top of that with some gel inside. Or you have specific, very small probes. We call them hockey stick probes for intraoperative work. They're only about 1 centimeter long and 4 or 5 millimeter thick, and it's bent like a end of a hockey stick. If you have the facility, if you have a intraoperative probe when you do the A fistula, and if you do the fistula anastomosis, and then you can put the probe on the anastomosis, you can see whether there's any technical problem. And if you have time, you can scan the whole vein. And it's a very good thing to scan the. We normally get a duplex scan done on the fistula either the same day or the following day. Because only a small incision at the end of the operation, the patient goes to the vascular lab and gets the full duplex scan. And if you find, it's very interesting, very often we find, we think it's a good fistula functioning absolutely normal, but you will find 30% narrowing, 50% narrowing at various points in the vein, which you will never know with the naked eye. And if you pick up such findings, then we keep them under surveillance, and 6 months down the line, it may remain the same, or one of the narrowings which was 30 or 50% might have become 70 or 80%. And if that happens, then we go and angioplasty and stent them. And in the past, we used to only angioplasty, but now in the recent past, we started to stent them more liberally with the either regulative stents or covered stents. I do not know how many of you do fistula angioplasty and stenting. We tend to inject local around the vein because you can see where the narrowing is. So when you dilate, even if it's painful, the patient doesn't feel anything because the local is infiltrate around the actual site of the stenosis. And we can do that on the table at the time of fistula if you have the access, or you can do it in the follow-up if the fistula gets narrowed. And when you get very tight stenosis, which is you're worried about rupturing when you are doing the fistula, you can use the covered stent and intentionally rupture the vein. But the vein is ruptured, but the covered stent is inside, so you're fine. So these are some of the other things which you can think about.
Joseph, actually, there are many centers doing angioplasties in our place, but I don't know, intraoperatively during surgery, I don't know. But this covered stents and stents, they cost a lot of money. So although the skills are here, but how practically you'll be able to do is an issue.
I think the question of covered stent is not for every case, but
you notice that he used the sling from the from the glove. Actually, it is not a regular sling.
Okay.
He takes from the rubber glove.
Rubber glove. Okay.
Yeah. So that is a good practice.
Okay.
And anything. There'll be a lot of finer issues to be discussed in technique of AV fistulas, and there could be more suggestions. But I think it's nearly 10 o'clock, and we'll stop here. And we'll definitely take smaller aspects of AV fistula, and not only AV fistula, other procedures as well, like PD in future. So let me thank the panelists, Dr. Rana, Sachin and Neil has left. Adrian, Vijay, and joined us. Narayana Prasad, and all the audience who spent nearly 2 hours with us today. And I think we'll have more interesting sessions in the future. And kindly give suggestions in the website or in the WhatsApp group for any smaller aspects of each of these issues to be discussed in future meeting. Because in the next few meetings, we'll be completing all major procedures, simple, straightforward methods. Then thereon, I think we'll have to go on to finer aspects. And from the seniors and organizers like Dr. Rana, Narayana Prasad, they should devise some mechanism by which there can be taking up intervention, especially in the likes of AV fistula, so that we will not have medico-legal problems. So I think they'll have to, these organizers and officials should work up and maybe take some lead from Western countries, what they have done there. Anything else? I think, anything you want to add, sir? Dr. Rana, Dr. Narayan?
Thank you, Vara. Thank you. Congratulate you. This is the point. Thank you.
Yes.
Sir, can I make a small comment?
Right.
Sir, we nephrologists from the Southeast Asia, a lot of us make arteriovenous fistulas, but a very few of us only do the intravascular interventions, like Dr. Adil. So a lot of us now have to start learning the intravascular procedures also. And my aim is to learn the intravascular procedures from Dr. Adil. And because I know he does a lot of good intravascular procedures. So a lot of us should now intervene in this area also.
Yes. Sir, can I say something?
Dr. Shailendra, he is a neighbor only. So anytime you can go across. Yes, again, as Dr. Joseph was suggesting, see, we'll have to see, Adil is nearly a full-time interventional nephrologist. See, if you have interest in clinical nephrology, transplant, critical care, and so on, whether we'll be able to spend so much time to acquire skills in all aspects of intervention, I'm not sure. So, I mean, right now, this is okay. But over time, I think we'll have to separate ways, and there would arise a community of interventional nephrologists who are practicing only interventional nephrology.
Bala, sir, I have a comment.
Yes.
And a suggestion. So we should make some competency courses that we should have. For example, I will keep there may be a coordination between the student and or the interested fellow and the teacher, a mentor. So then we get 7 or 10 cases for them. For example, is a fistulography. Fistulography is a very easy thing, but it's an apprehension only. There is nothing. How to put a sheath, what is the sheath, different kinds of sheath, where to put a sheath, artery or the vein from below or above. So that way, I'm suggesting that from this forum, we should make something that we should coordinate the to both of the teacher and the student, then to keep the patients and give the certificate from some authentic source.
Yes. So there should be some mechanism by which ISN and forums like that authenticate centers, centers of excellence or centers where they are good enough to train. Then once they complete, then the certification may be.
It in the parts that the fistulography, fistuloplasty of the radiocephalic juxtaanastomotic segment, mid-body, cephalic arch, central vein, like that. It should be in the parts. Nobody is actually, all are actually busy in their practices, so their own places. So, but they can spare some 1 or 2 weeks for these things, for the permacath, PD catheters, and all the interventions like that.
I think
my suggestion.
I agree with that, with what Dr. Jairaj is saying, because here in America, I'm part of ASDIM, and we give certification for people. So centers are certified that if you train here, then you can go and do your procedures. So, but like he said also, you have to spend time, maybe a month, maybe 2 months. And if all of us are married with children, your wife is not going to let you do that.
Yeah, Adil, I think we'll plan something on that line. Before that, I think Narayan Prasad, are you there still? I think he has left. I think we should make them first identify centers, like Adrian said, 5-6 centers at least in the country, and let people contact them and give quantify, so many procedures. Like in UK and US also, I think they should have had so many procedures with under supervision, independently, like that. Some guidelines. I think ISN by itself, they may not have time. I think from this forum and interested people like Vel Aravind, Adil, me, and all, youngsters should make some criteria. Will let us correct it with Tushar and others from outside, and consolidate it and pass it on to ISN to sort of work it out. We'll try to do something like that.
Interesting fact, in the United States, it's easier for you to get certification in fistulograms rather than get ultrasound training. Right now, there's only one center that has done as certified, that is in Georgia, Atlanta, to go and do ultrasounds. And in India, it should be the opposite. I'm sure you have more ultrasounds like Vel and all are doing. It's phenomenal work. It's easier, I'm sure, with ultrasounds than fistulograms.
I think we reduced the number of fistulograms dramatically when we had a good vascular lab. But the main thing about ultrasound is hugely operator dependent. So you need to have excellent scanning skills to get because all of us can get the image, but to get the flow, the velocity, the grade of stenosis, to pick up central stenosis from the flow pattern in the distal vessels, and that type of information comes with experience.
Okay. I think we have spent quite some time. Thank you. Let me thank again all the panelists and other seniors and participants who actively got involved. And the recordings will be available in a week's time in the website. And I noticed that today the attendance was much less than previous meetings. And this itself shows. See, whenever I try to talk about interventions to nephrology audience, they are comfortable with very simple things like central vein catheterization or PD catheter and anything, just beyond that. Even in PD catheter incision, if I talk about suturing the cuff, inner cuff, they're not happy. They are scared and they want to get like that. So AV fistula is in that category right now because instantly they think that this is not for me. So maybe that was one reason. And plus, again, I told you this week there were a lot of intervention and other forums going on. But anyway, with the recordings available, others should be able to see it. And in future meetings, we'll try to cover other areas. Thank you.
Excellent. Thank you. Thank you.
Good night.
Good night.
Wait பண்ணுங்க.
Yeah.
Thank you, sir. Shall we stop, sir?
Yes, yes. Yeah, we'll leave.
Yes, sir. Good night, sir.
Okay, good night.